At this time, I get the pleasure to introduce briefly here my colleague, Dr. Radhika Damija.
A lot of this is going to be recap, but I did want to spend some time discussing clinical practice guidelines that many of you in the audience and online helped put together. A second on the first slide, as you notice, we did use the term LMNB1-related autosomal dominant leukodystrophy, and I would agree with our keynote speaker, Dr. Aniko, that we should probably be using gene-specific terminology as we have come to learn of many other dominant leukodystrophies. So going forward, as we write literature on this disorder as a group together, if we want to put forth LMNB1-related autosomal dominant leukodystrophy, it'll just make it more uniform. So moving on, I'll review the clinical practice guidelines that was put forth by our expert panel members, many of whom are in the audience and online. I wanted to review some of the literature, but most of this has been covered, so I'll maybe just skim through it or highlight some points, discuss knowledge gaps, and then briefly mention a partnership with GLIA and launching the natural history study, hopefully very soon, as Bishan mentioned, and then just future directions, where do we go from here? So clinical practice guidelines focused at these areas. How do we diagnose patients? How do we manage these patients? And how do we follow these patients? A lot of work went into this, and a lot of people helped make this happen. So thank you to everybody who's on this. So I wanted to start with this pedigree. This is from the 1984 New England Journal, where the first family for ADLD was described. This pedigree is just very impressive, not only because it's large, it shows so many members affected, but it also has 4 generations in clinical practice and genomics. We usually just do 3 generations. So this was a very detailed manuscript, and a lot of things were highlighted, which actually haven't changed in the last 2 decades of studying these disorders. Usually these families are very large, as has been pointed out, because it is a dominant disorder that doesn't present till later in life. It's a slowly progressive chronic neurologic disorder that stands true. This first family had 21 individuals affected, and 20 of them were evaluated before the availability of CT, and therefore were given a diagnosis of presumed or possible MS. And only till the proband, who was a 46-year-old gentleman, was brought to the clinic and gave this detailed history that it was felt that this was probably genetic. And then these clinicians who were really, really smart did further studies, including pathology, and figured that this didn't look like MS and should have a genetic basis. Fast forward, we have Dr. Padia in the audience who figured out the genetic basis. So the overview hasn't changed. It is a very unique leukodystrophy that is adult onset. The onset is in the 4th to 5th decade of life, usually with autonomic symptoms as the first manifestations. This paper really said that all men had bladder dysfunction and were impotent. That's the terminology that was used in this New England Journal paper, and said all women presented with bladder dysfunction. That kind of holds true. And then subsequently, you have motor and cerebellar impairment, including spasticity, ataxia, and it's slowly progressive. And we've already gone over the MRI and spinal cord findings that can precede clinical manifestations by decades. How do we manage these individuals? So Dr. Appleberry gave a very nice overview of how she takes care of patients with ADLD, and I'm hoping most neurologists do provide such comprehensive care. So management is symptomatic, but there is no cure. We are actively moving towards novel therapies and progressing in that direction, but we still have ways to go. Importantly, when we started to look at this disorder, we felt that there were no guidelines of how to diagnose, manage, or follow these patients. And maybe it was time to look at it systematically. So the aim of this study was to assemble ADLD clinical experts and use a modified Delphi method to develop consensus guidelines for the diagnosis, management, and surveillance of patients with ADLD. We briefly heard about what Delphi method is, and I'm going to, in a previous talk, and I'm going to share how we did modify it a little bit with input from methodology experts to make it work for us. Standardized care is a key initial step to improving outcomes and to start any kind of natural history study that would potentially lead to any therapeutic development. As in the audience, this was pointed out that you could make an EPIC smart document. So I guess we'll start with standardized care and then move towards that. So the expert panel was formed by two of us, myself and Bishan Singh from ADLD, where we identified people who were experts on ADLD, who had interest in being part of this and had cared for patients with ADLD. The first International Symposium on ADLD that many of you attended, including Dr. Cousin from Mayo Clinic, where this partnership started. So we identified experts from that collaboration. In total, we had 9 clinicians and scientists from Europe and USA from 5 different institutions that formed our expert panel member. We then included a biostatistician, a guideline methodologist, and eventually this was circulated to additional experts for their input. What is the scope of this guideline? So the target patient population is to apply to patients with ADLD or suspected of having ADLD. And we wanted to focus on clinical diagnosis, summarizing genetic testing selection, management, and surveillance of individuals with ADLD. This certainly does not intend to replace clinical judgment. Before we wrote this guidelines and went on to the Delphi, we had to do literature review. And I, again, wanted to highlight some of the papers which have already been highlighted today in different talks, so I'll be brief. But we, with the help of a medical librarian, we searched for available electronic databases with the term Autosomal Dominant Leukodystrophy. As you know, it's a broad term, so we got several different, we got about 160 total manuscripts, all of which, the abstracts of all of which were reviewed, and eventually we felt like 78 met criteria that focused on ADLD. They were broken down into 5 categories: clinical features and diagnosis, genetic testing and diagnosis, neuroimaging, management, and therapeutics. And this literature review formed the basis of the questions that were distributed among the expert panel for their input. Our modified Delphi approach consists of 2 structured questionnaire rounds, and then eventually using surveys, and then 1 virtual consensus. The initial survey was distributed among the EPM. They were asked to answer it, was modified, and then it was circulated again. And then eventually a virtual consensus meeting was held. The questions were divided into the 5 sections that are highlighted, and there were 3 questions in clinical diagnosis, 4 genetic testing, 3 on imaging, and 9 on surveillance and management. And all experts gave final approval to the final version before it was submitted. So the results, they were broken down into 3 categories, or each recommendation was broken down into 3 categories, depending on how much evidence we had. And as you know, in the audience, that the literature evidence around ADLD is limited. And so the guidelines that were strongly supported were few, but we needed consistent evidence for recommendations that were strong. Moderate was inconsistent evidence, and weak where there was no evidence at all. And it was just based on clinical experience. I'm going to skim through this. A lot of us have already talked about this paper, but a couple of papers that really were the heart of this literature review. One is Dr. Vincent's clinical and radiological review that studied 23 subjects. All patients had autonomic dysfunction. Pyramidal signs are very common. Ataxia, stutter exacerbations have been described as well. And so I'll kind of skim through this. We've talked a lot about this. The other area we looked at is the genetics, and is there a genotype-phenotype correlation? As we now know that most families with ADLD have a unique LMB1 duplication, but very rarely they can have a heterozygous deletion upstream of the LMB1 gene. And based on literature, we think that the deletion, there is some genotype-phenotype correlation, and patients with deletion show an earlier age and onset and often lack early dysautonomia. And again, a lot of you in the audience are on this paper, but this looked at 5 patients from 3 families. And again, the observations made in patients with deletion was that they're typically younger onset when they have their symptoms, and they do not have early autonomic nervous system involvement. ADLD is almost always familial with autosomal dominant inheritance, and the EPM observation was that they had not seen de novo cases in clinical practice. Coming to management, there's no really consensus on how to manage these patients, as we have heard that these patients have myelopathy, and so management revolves around kind of taking care of their myelopathy, and autonomic dysfunction is very limiting, and so symptom management for autonomic symptoms is also offered to these patients, but there is no consensus around what are the best practices. So moving on to what our recommendations were based on our modified Delphi approach, literature review, and our EPM expert opinion. So in terms of diagnosis, I think we have very strong evidence to support how a diagnosis should be considered. The abnormal brain MRI findings that were discussed in detail in the morning, in the presence of constellation of clinical features that are characteristic of this symptom, a positive family history of dominant inheritance, and brain and a spine MRI showing atrophy. Typically, this disease has gradual progression of symptoms. This is a patient where we can see ADLD changes over time. And again, I'll kind of skim through this. Pseudo-exacerbation, which essentially means that patients can have acute worsening with illness followed by recovery to baseline, can be seen, has been described. And I think in the morning there was a question, is there an MRI correlate with diffusion restriction during one of these worsening? But that we don't know. That hasn't been looked at. ADLD is a fully penetrant. I guess we might have to revisit this, but in terms of the pathogenic duplications, it is fully penetrant. And the diagnosis should be established in a patient with suggestive clinical MRI findings, positive family history with either a pathogenic duplication or rarely a heterozygous deletion upstream of the LMNB1 promoter identified on genetic testing. So these all have strong evidence to support how you would diagnose the patients. Moving on, if you have a patient with isolated LMNB duplication in the absence of family history or suggestive clinical or MRI findings, that would not give them a diagnosis of ADLD. And however, we recommended that these individuals be monitored for future development of symptoms. Single gene testing that can identify LMNB1 structural variants, duplication, or deletions at high resolution should be used for diagnosis. And whole exome sequencing or next generation platforms would typically not be recommended as first-tier testing, as it may miss LMNB1 duplication or upstream deletions. In terms of clinical assessment and surveillance recommendations, there was really no limited evidence, inconsistent evidence, or no evidence, and therefore our level of evidence in giving these recommendations is weak. But we felt, our clinicians felt that patients should be examined in baseline, that like they would be, and then annually thereafter to monitor for their myelopathy and disease progression. Tail table testing and neuroimaging would be done at baseline, and then really based on their disease progression. So if they're clinical worsening, then you would repeat them to help guide management. And a series of minimal images were recommended that should be part of their MRI scans. Again, as we learned through the course today, that cognitive deficits typically are not present early on and can be seen late in the disease course. And we recommended that patients have neuropsychometric assessment at baseline and then based on disease progression to help guide management. And when patients develop neurologic symptoms, which most do, then they should be referred to urology for expert care. In terms of further management recommendations, multidisciplinary care is recommended. A neurologist, physiotherapist, genetic counselor, or geneticist should be involved in their care at a minimum, and then additional providers based on individual patient needs. Management of spasticity, you would start with non-invasive treatments, followed by botulinum toxin, followed by invasive treatments like intrathecal baclofen, and early referral to PM&R should be considered when available. In terms of genetic counseling, all patients with genetically confirmed ADLD should be counseled that the risk of transmission to the future generation is 50%. As we discussed, this is an autosomal dominant disorder. And then all patients with ADLD and at-risk individuals, i.e. relatives of patients with ADLD who wish to conceive, should be offered prenatal genetic counseling and informed about the option of pre-implantation genetic diagnosis and possibility of oocyte or sperm donors. So those are our recommendations. There are certainly limitations to these recommendations. EPM or expert panel member experience is varied, and there's limited literature for this ultra-rare disorder. In terms of future research, I think the two symptoms that are most limiting to the patients are autonomic and spasticity. So carefully looking at perhaps certain strategies would work better for these group of patients can be areas of future clinical research. So in conclusion, for the first part, these recommendations do pave the way for further collaborative research efforts towards a natural history study, because if we have standardized guidelines, our retrospective natural history study can be more robust. It can help define endpoints for clinical trials and eventually cure that we're all hoping for. So briefly about the natural history study. So as I mentioned earlier, and Bishan as well mentioned, that we are leaning and collaborating, we're leaning towards GLIA and collaborating with them. So GLIA is a Global Leukodystrophy Initiative Clinical Trials Network, which is a network of research institutions around the United States that are supported by their multi-center biorepository protocol, and they help map longitudinal clinical course across all leukodystrophies. Prospective clinical trials are uniquely challenging in rare disorders, and there are many reasons, some of which are listed here. First of all, there's delay in diagnosis. You would limit inclusion if you were doing a prospective clinical trial to patients post-diagnosis. And overall rarity and slow progression of the disorder would also make a prospective study, a natural history study, a bit more challenging. And so GLIA has been studying several other leukodystrophy, mostly pediatric onset, in a retrospective manner for some time now. And they have standard operating protocols for all their leukodystrophies, which we are going to use for ADLD as well. Essentially what it is a standardized way of chart reviewing. So real-world data collection using chart review allows retrospective data collection over years. You could potentially go back decades in a patient chart. It can also include patients from various locations, as we were discussing about geographic and mobility limitations. This would enable us patients to have had care anywhere, but give access to us or to the medical records to systematically kind of abstract data. And then patients who have passed away potentially can also be included. And thus it diversifies your retrospective natural history study. And once the patient has consented for a retrospective natural history study, they keep getting their clinical care, but you can periodically go back to their chart and kind of abstract that data as cross-sectional or, again, retrospective. So among their standard operating protocols, that's what they recommend that key variables should be. And that's where we are right now in our process of the retrospective natural history study. Katie Mamilo, who's our research fellow, is sitting at the back. She has been hired to work on this natural history study, and she's been diligently working on it and has essentially completed the Excel of all these key variables. Including demographics, diagnosis, presentation. So encounters are each time a patient has had a visit, you would be abstracting standardized sort of information from the chart. And then you would create encounter-linked functional scales. For example, each encounter, you would then see what the EDSS score could be, again, applying retrospectively. And then time to event measures are very unique in this retrospective natural history study. An example would be what would be relevant to a patient, for example, when they lost their mobility or became wheelchair dependent. So time to loss of mobility or time to use a wheelchair, all those event measures would be collected, and these would be great to potentially study for a clinic therapeutic option as well. So what are the challenges for this? Certainly, as we discussed, the patients would have had received care in different institutions, so there'll be heterogeneity in the quality of the medical record, and hence clinical care guidelines perhaps can help overcome at least this challenge. There could be unclear documentation of a medical event. There could be missing data. But I think as we go through, we will learn how to overcome these challenges and abstract the data as best as we can. So in conclusion, ADLD is an ultra-rare disorder and drug development is uniquely challenging. And so we have come together for interdisciplinary collaboration. We're going to move towards retrospective medical record data collection, which will pave the way for a retrospective natural history study, a rigorously done natural history study. And so using existing glia mechanism and they've used it for several other leukodystrophies. And so we have confident that this hopefully will work for ADLD as well. And then eventually, we learned so much about variables and it gives us hope. Again, eventually moving into prospective natural history study. With that, I'm going to end, but then I also want to thank a lot of people. So I want to take you back to 3 or 4 years ago. I was in Arizona and I get a phone call from Gurdesh, who's sitting in the audience, and he said, have you ever heard of ADLD? And I was like, I think I've heard of ADLD. I'm a neurologist and a geneticist, and so I have heard of ADLD. And he, wanted to bring the ADLD Center and hopefully work with Mayo Clinic. And I said, well, I don't think I can help you, but I can connect you with the right people. And I gave him the contact of Margot Cousin. And, 4 years here, we are all here together. So I want to thank, Gurdesh and Dr. Cousins for involving me, but then want to thank everybody that's listed on this slide. And then all the collaborators who answered my surveys, answered my emails, looked through the draft. And hopefully we'll get it published somewhere. I'm persistent. So thank you everybody for your time and coming today.